So, good evening, friends. Welcome to this Tuesday evening seminars and student programs that's called master classes. This has been a part of almost last 7 years from the city of Hyderabad and with association of Yashoda Group of Hospitals. So we tried to bring different topics of interest for the students, their exams, and it happened to us that all the senior examiners across the length and breadth of the country have been a part of it. And today we had a we are having an interesting case of sepsis and a very common phenomenon in our day-to-day practice, and also a kind of routine exam case where most of our students come across this case in different formats, either it is DRNB, DM, or IDCCM, the sepsis being a common case. And when we thought about this kind of very common prototype of case, we had two examiners in our mind. And we have none other than Dr. Srinivas Samvedam sir, a academician, a teacher, a clinician, a core, hardcore, student-friendly teacher for the last almost 2 decades and more. Srinivas sir has been HOD and department head in many corporate hospital and quaternary care centers in Hyderabad, and right now is leading the team in Sindhu Hospitals. And Srinivas sir has been in many positions in ISCCM and been the past president of ISCCM National. Sir, it is always a honor for us to have you on board and interact with our students, sir. Thank you for accepting our invitation and being a part of this program. Srinivas sir, thank you very much.
Thank you, Venkat, for inviting me to this very popular and area of need program, which most students actually benefit from and have benefited from for the last 7 years, as you said. Thank you, and very much congratulate you for this effort.
This has been only possible because examiners like you, seasoned teachers, who could actually spare their time and being a part of it and guiding all of us. Thank you. And we have another examiner, Sunil Karan sir. He hails from the neighboring city of Bangalore, and he heads the Department of Critical Care Medicine in Manipal Group of Hospitals in Bangalore. And both of them has been teachers for us, and being we all grown up looking at both of them in their clinical acumen and the teaching and guiding us. Sunil sir, it is always also honor for us to also have you on board. Thank you for accepting our invitation and being a part of it, sir.
Thank you, Dr. Venkat. I think, as Srinivas rightly put it, it is a privilege to be part of your program, which masterclass, which has been ongoing for such a long time, and a lot of students, including my students, have benefited. And also, I think today uniquely placing me with Srinivas, who has been my old colleague. We trained together. We were roommates, good friends, family friends, a lot of things we share together, me and Srinivas. I think good nostalgic memories of the past. And I'm glad to see him very relieved after his president term. I'm seeing the smile back on Srinivas' face, which has been missing for the last 1 year.
He was a core teacher more than anything. Both of you were core teachers.
No, the relief of his on his face, I could very well see. And I think his eventful 1 year, I think, has given us, society, a new impetus to grow to greater heights. Thank you, Venkat.
Thank you, Sunil. Thank you so much, Sunil.
The reason behind why we actually tried to bring both of you, it was not a deliberate attempt. It was a student's favorite demand and requirement when they keep on calling. These sessions, we need a recorded video sessions. So both of you have been on the forefront. We thought of the sepsis topic and brought you both together. So without much taking time, I hand over to Dr. Vinay and Ankita, who has been postgraduates in DRNB Critical Care Medicine in Yashoda Hospitals, Secunderabad, to bring this case. I hand over to both of you, sir. Both of you can introduce and make it full screen.
Good evening, sir. Myself is Dr. Vinay. I'm a DRMB resident in Yashoda Hospital, Secunderabad.
I'm Dr. Ankita from Yashoda Hospital, Secunderabad. I'm doing DRNB first year.
Not full screen is not happening.
Sir.
Please click on resume.
Resume.
Resume. Please click on resume.
Good evening, all. Today we are
Please,
presenting
can
a
you put it on slideshow mode? It'll be better.
Now please go to slideshow mode or full screen.
full screen, sir. Full screen. Sir.
No,
No, it's
press
not
that
full
red.
screen. There is something called as presenter mode or slideshow on the top of your window, no?
The red button down also. The
There is
play.
home, right? Home is on the red. Or yeah, red button
Yeah.
down also. Yeah, both ways.
Yeah.
Red button on the bottom, Vinay.
This more.
More.
Option is correct. So I think
What
from
is-
back it will do. It's not going back also.
No,
Press
red.
F5. Press F5.
Not helping.
We'll stop sharing, sir.
Ah,
Then
stop
we'll
sharing,
do
sir.
slideshow and then we'll come. Then how will come?
Say it again.
It's okay, sir.
It's okay. Go ahead.
Yeah, good. Yeah.
Good evening, everyone. Today we are presenting a case of sepsis. A 58-year-old male presented to the patient came to the hospital with complaints of pain over the left lower limb since last 3 days. Pain was mild initially, but rapidly progressive. Swelling and redness since 3 days. Fever, high grade, intermittent since last 2 days, and skin discoloration and blisters in the right lower limb since 1 day, and decrease in the urine output since 1 day. He had a history of trivial trauma like thorn-pick injury while working in the fields 4 days prior, associated with generalized weakness and decrease in oral intake. Regarding past history, he's a known type 2 diabetic mellitus on Glimepiride 1 mg twice daily and metformin 500 mg twice daily, and hypertensive on telmisartan 40 mg BD and clinidipine 10 mg BD. No history of any peripheral vascular diseases, not on any immunosuppressive drugs, no history of any drug allergies. General examination in ER, patient is moderately built, no pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Local examination shows diffuse swelling with ill-defined erythema. Skin shows dusky discoloration with hemorrhagic bullae, severe tenderness, pain out of proportion. Local warmth present, crepitus felt on examination, and areas of skin anesthesia noted. Systemic examinations, cardiovascular like systolic S1, S2 present, sinus tachycardia, no added sounds. Respiratory bilateral normal vesicular breath sounds, no added sounds. And parabdomen was soft, no visible scars or swellings. And CNS of GCS 13/15, no neck stiffness, pupils bilateral equally reacting to light. Initial vital source, temperature, febrile 1 or 2 degree Fahrenheit, and a pulse rate of 120 per minute. Peripheral pulses feebly felt, and BP was 80 by 50, 80 systolic by 50 diastolic, respiratory rate of 26 per minute, and capillary refill time of 4 seconds, and saturation of 96% on room air. Patient general drowsy, erosible to verbal commands, and occasionally irritable. In ER, initial ABG shows pH of 7.18 and PCO2 of 26.1 and PO2 of 94.2 and bicarbonate of 17.1 with the lactates of 5.85, sodium of 139, chloride of 109, and potassium of 4.5 with the anion gap of 12.9. On POCUS, IVC shows 1 centimeters completely collapsing. On lung ultrasounds is bilateral A profile. And to echo screening consists of mild LV dysfunction with global hypokinesia of LV. Patient had given with fluid bolus of 1.5 liter crystalloids in ER and sent 2 sets of blood cultures. Police catheterization was placed for output monitoring. Patient was started on injection piperacillin tazobactam 4.5 grams IV 6th hourly, injection linezolid 600 mg IV 12th hourly, and injection pantoprazole of 40 mg OD, optineuron of 1 ampoule IV OD, injection thiamine 400 mg IV OD. Sent for initial labs of CBP, LFT, RFT, and PTINR with CUA and HbA1c. Vascular surgeon opinion was taken at bedside in ER, and bedside debridement was done and sent a wound swab for gram stain and culture sensitivity analysis. Patient was shifted to medical ICU with injection noradrenaline support of 0.1 mic per kg per minute. In ICU stay, CVC and arterial lines are secured. Urine output is 30 ml, high color in the first hour. Repeat ABG was done. Suggested of pH of 7.291 and PCO of 30.6, pivot of 88, bicarbonate of 20.09, lactates of 2.8. Continued on balanced crystalloids with 80 ml per hour with the serial monitoring of capillary refill time and lactates and IBC assessment. GRBS was 388 milligram per deciliter, started on insulin infusion, check GRBS accordingly. Day 2 in ICU stay, patient was taken for emergency surgical exploration and extensive fasciotomy and debridement was done under the general anesthesia. Necrotic tissue was sent for analysis, shifted to medical ICU with minimal noradrenaline support of 0.2 mics per kg per hour with the BP of 110/68 mmHg, GRBS of 268, urine output of 40 to 50 ml per hour, saturation is 97% on room air. Continued fluids at 80 ml per hour and continued on insulin infusion. And repeat ABG post surgery shows pH of 7.32, PCO2 of 30.8 and PO2 of 93, bicarbonate of 21.2 and lactates of 2.2. Continued on antibiotics as initiated early. Day 1 lab shows HB of 11, TLC count of 22,000 and platelet count of 1.48 lakh. Blood urea is 34 and serum creatinine of 2.2. Sodium, potassium chloride of respectively 135, 3.2 and 98. LFT is initial lab shows total bilirubin of 1.1, total bilirubin of direct 0.3, indirect 0.8, SGOT was 38, SGPT was 43. Alkaline phosphate 143, GGT was 18, albumin was 3.2, PT 20 seconds, INR of 1.58. On day 2, routine labs shows HB of 10.5, TLC count of 23K and platelet count of 1.35, blood urea of 28 and serum creatinine of 1.8. Sodium, potassium chloride of respective 138, potassium of 3.6 and chloride of 105. Day 3 labs was HB of 9.6, TLC of 19K and platelet count of 1.4. Blood urea was 28 and serum creatinine of 1.4. Sodium, potassium chloride respectively 135, 3.5, 108. PT 18 and INR was 1.28. This is a trend of ABGs during ICU stay compared to the initial ABG in a year. The pH of 7.1 in first done in year, PCO2 of 26.1, PO2 of 94.2, bicarb was 17 and lactates of 5.85. And repeat ABG after 6 hours, it shows of pH of 7.291, PCO2 of 30.6, PO2 of 88, bicarbonate of 20.9 and lactates of 2.8. Day 2 ABG shows pH of 7.32, PCO2 of 30.8, PO2 93, bicarbonate of 21.2, lactates of 2.2. Day 3 day 3 ABG shows pH of 7.42, PCO2 of 32.6, PO2 95, bicarbonate was 22, lactates was decreasing trend with last value was 1.8.
Srinivas sir and Sunil sir, we can actually, I think, interfere and ask questions from the day 1 so that it will.
Yeah. Can you make a brief summary? Now you gave a detailed kind of or a semi-detailed history. At the end of history examination, in the exam, always make a small summary and give the differentials.
Yeah, sir. And 56 years old male came with complaints of injury, prior injury, followed by history of multiple episodes, intermittently high-grade fevers with decrease in urine output and little altered behavior. On initial evaluation in ER with initial vitals with suggestion of he's on sepsis, septic shock with the differential diagnosis might be any cellulitis, erysipelas, and might be probability of necrotizing fasciitis and any unknown bite, snake bite or any insect bite, any vasculitis.
Can you make it a little briefer? Can you put this entire presentation of this patient in one sentence?
Is a case of poorly necrotizing fasciitis with sepsis with septic shock with AKA with poorly controlled diabetes.
Yeah, so to refine it, you say this is a sepsis and septic shock of skin and soft tissue origin occurring after a breach of the skin and the skin interface due to an injury in a poorly controlled diabetic. This is what your one sentence brief should be. This is what is expected in your exit exams, where people keep asking, summarize, summarize, summarize. You should be able to give the entire gist in one sentence. This is very important. Okay.
Okay.
Now, are you able to hear me?
Yes,
Yes,
sir.
sir.
Yes.
Because somebody has posted no audio, so I was worried whether it's my audio which has failed. Okay. So now you said necrotizing fasciitis. What is the class of grade of necrotizing fasciitis in this patient, and how does it impact the treatment and choice of therapies for this patient?
Might be it's a grade of grade 1, sir. Grade 1 of necrotizing fasciitis might be polymicrobial, suggest of polymicrobial, sir. Like like with tantric injury, it might be a polymicrobial. That was grade 1. And another grades of necrotizing fasciitis was
So
grade.
what you are saying, polymicrobial versus monomicrobial, is the types of necrotizing fasciitis.
Yes, sir.
So you get a type A and type B necrotizing fasciitis, where in type B you get usually polymicrobial with gram-negative predominance, whereas type A is gram-positive. That is the types. The grades will be the depending upon one, the extent, two, the involvement of deeper tissues, and three, the origin, existence of um, existence of organ dysfunction. So this is the grades of uh, necrotizing fasciitis. Why is it important? Why do you need to know the extent of necrotizing fasciitis?
Early debridement might be a life-saving for that.
No, so the choice of antimicrobials will depend upon the extent of necrotizing fasciitis. If the necrotizing fasciitis is above the inguinal ligament, then a combination therapy is recommended, and one of the recommended antibiotics of choice in patients in septic shock with necrotizing fasciitis extending above the inguinal ligament is daptomycin. That is important for you to grade the necrotizing fasciitis. Okay. Now, if I want to improve your presentation and make your diagnosis more contemporary, in sync with what is currently being thought about sepsis, I can ask you one question. Which phenotype of sepsis is this one? How many phenotypes of sepsis are you aware of? How many phenotypes of sepsis are known to science at this point of time? Is described in very detail. But what is this one predominantly representing? Phenotypes. Have you heard about phenotypes of any disease for that matter?
Phenotypes in ARDS, yeah,
Phenotypes in ARDS. So there are also 4 phenotypes in sepsis: alpha, beta, delta, and gamma, depending upon the predominant manifestation. Patients who present with predominant hypotension and say signs of organ hypoperfusion come in the alpha phenotype of sepsis. Those who come with predominant acute kidney injury into the beta phenotype. Those who come with coagulopathy and hepatic dysfunction come into the delta phenotype. And those who present initially with multi-organ failure come into the gamma phenotype of sepsis. This is important because the prioritization of your therapies, the early initiation of RRT, the screening for thromboinflammation and coagulation failure, all will depend upon which phenotype of sepsis you are dealing with. At a DRNB DM level, you are expected to know the phenotypes, the discussion, and the different phenotypes of sepsis. Okay.
In light of the new sepsis
Yeah.
guideline, do you want to qualify your diagnosis of sepsis a little more? I know you have said sepsis, soft tissue, Do you know what are the types of descriptions of sepsis given in the new guideline?
Yes,
Yes, sir.
definite sepsis.
So this comes under what?
No. De-
Is it definite or anything else you want to brand it?
Definite sepsis.
Yeah, this is definite sepsis, no? Because you have a potential source and you have all the other signs to suggest sepsis, right? Yeah. Just another clarification. What was the albumin level? Do you have any detail on that? I don't know whether I missed it on the day of admission.
Yes, sir. 3.2, sir.
3.2. Okay. So have you got any thoughts on the type of metabolic acidosis when he presented to you?
Yes, sir. Initial normal anion gap metabolic acidosis, sir, with partially compensated respiratory alkalosis was there.
Partially compensated respiratory alkalosis. How do you say that?
The Winter's formula 1.5
Ah.
into bicarb plus 8
Mm.
plus or minus 2, sir.
Mm.
It will come around
It's plus or minus 2, no? It's almost.
sir, plus or minus 2.
So it's just metabolic acidosis with. Tell me the diagnosis again. Metabolic acidosis with the.
With respiratory alkalosis, sir.
Do you call it respiratory alkalosis if it is equal to what you have calculated? If you take the plus or minus 2 also, it is 28, isn't it? Roughly.
Yes, roughly
1.5
partially
into
compensated.
17. Huh?
That's I call partially compensated, sir.
Yeah, you can't say that. So remember the nomenclature of metabolic acidosis or anything, when the compensation is adequate, you can't add a second disorder. Okay, never add. It will be appropriate compensation. If it is not, then only you can say there's another disorder. And why do you call it normal anion gap?
Calculated anion gap initial was 12.9, sir.
Have you checked the validity?
Yes, sir. With albumin.
Because your lactates are 5.85, no? So quite obviously you can't have a normal anion gap metabolic acidosis.
Sir,
Yes, sir.
we checked with corrected albumin gap also, sir. It's coming around 14.9, sir.
Okay. No, I mean some error might have been there in the measurement itself. Very unlikely that, or many times chloride is not very well calibrated, so that could be because you have got a lactate of 5.85.
Yes.
So there has to be an element of increased anion gap metabolic acidosis. Okay, yeah.
And you spoke about a collapsing IVC, right?
Yes, sir.
What is the relevance of a collapsing IVC in a spontaneously breathing patient who's tachypneic, alkalotic, and has a metabolic acidosis, IVC index of more than 50%? What is the relevance? Why did we do that? And how are you going to interpret that collapsibility of the IVC in a spontaneously breathing tachypneic and acidotic patient?
It's not quite reliable in spontaneously tachypneic the metabolic acidosis patient, sir. Might be it collapsibility index like around less than 50%. There might be a chance of fluid deficient, like a volume deprived. We can give in that patient, sir. More than 50% collapsibility index means there is a high chance of volume overload might be there, sir. But in this kind of patient, collapsibility, severe tachypneic patient, there is a less likely, we can't correlate completely is volume deficient with that IVC collapsibility index.
What is the IVC diameter? Sorry, I missed that.
1 centimeter, sir.
Okay.
Go on with the presentation. Thank you.
Day 3 in ICU, shock was resolved. Blood culture flagged positive for GPC in pairs. Patient initiated on oral feeds. IV fluids stopped. Urine output was 50 ml per hour. GLBS control and stopped insulin infusion after switching to subcutaneous route. Patient was shifted to step down ICU. Final diagnosis was like necrotizing skin and soft tissue infections with sepsis, septic shock with organ dysfunction like AKA and septic cardiomyopathy, sir.
Why did you say septic cardiomyopathy?
My initial LV function was around 46, sir, with the global hypokinesia of LV was there, sir.
Why is it? Why did the patient have a global hypokinesia and an LV dysfunction despite the patient having sepsis? Why do you think he had it?
Stress induced, like septic cytokine storm induced, or septic like endotoxin induced.
What is the impact of metabolic acidosis in myocardial contractility and vascular tone?
Causes LV dysfunction, sir.
Yeah, so in an acidotic patient whose acidosis is persistent, you have not corrected it with whatever source control or whatever. Every LV dysfunction does not mean it is cardiomyopathy, first point. Second, there are definite criteria to say septic cardiomyopathy. There are definite criteria to say there is stress-induced cardiomyopathy, right? We haven't seen a troponin I, we haven't seen a BNP on this patient, okay? So without discussing, without mentioning the BNP, you cannot make a diagnosis of a septic cardiomyopathy. It can be myocardial dysfunction without a cardiomyopathy in the presence of a significant high anion gap metabolic acidosis. All right.
Okay.
What are the
Yeah.
types of stress cardiomyopathy you know of? Or what are the patterns of stress cardiomyopathy? Commonest is what?
Takotsubo cardiomyopathy, like.
So what is the where is the dysfunction there in the which part?
LV apex ballooning was.
Other types you know of?
Don't know, sir, other types.
So be careful with the words you throw. The other types is generally there is more of a focal. So it's either apical, basal, mid-ventricle, or focal. These are the four types. So if it is a global one, it has to be some other some other etiology or some other complication. It cannot be a stress cardiomyopathy. So be very careful when you brand somebody as stress cardiomyopathy because the implications become very different. Yeah.
Okay, sir.
What are the risk factors for Sakasubo cardiomyopathy? What are the risk factors for the so-called stress-induced myocardial dysfunction or stress cardiomyopathy? What are the risk factors? What are the risk factors? Am I audible?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yeah.
Respects.
So, fluid unresponsiveness, rapid escalation of vasopressors, prior diabetic status with poor glycemic control as defined by an HbA1c of more than 7, okay,
Okay, sir.
and refractory to steroid therapy. The vasopressor responsiveness refractory to steroid therapy. These are the identified risk factors for Sakasubo cardiomyopathy. It's not the extent of tachycardia, it's not the duration of tachycardia that matters. It is the storm that matters. I noted that you mentioned that you changed to balanced crystalloids somewhere midway between your resuscitation.
Yes, sir.
Yes, sir.
Why did you make that decision? What has triggered you to go from saline to balanced crystalloid at that point of time?
Initially, also we started with balanced crystals only, sir.
Sir, in ER also, they have started with balanced crystalloid, sir. Plus patient
Why?
already in metabolic
So what is
acid.
the rationale? A patient who comes de novo off the streets into your ER or ICU, what is the evidence in favor of starting balanced crystalloids versus 0.9% saline?
Evidence, recent meta-analysis suggests of there is a 90 days decrease in mortality with less renal events like RRT, but with no benefit in mortalities. 90 days mortality benefit was there, but with less renal events and decrease in
What is the SSG 2026 guideline recommendation of using balanced crystalloid?
Balanced crystalloids are preferred over
normal saline,
normal
sir.
salines.
From day one, from day zero?
Yes, sir.
Yes, sir.
So for patients who have been resuscitated with the minimum 30 mils per kilogram body of crystalloid with an ongoing fluid requirement and still hypovolemic or showing evidence of fluid responsiveness, it is preferable to go with balanced crystalloids. That is the recommendation. It's not that everybody who comes off the street gets balanced crystalloid. It is only after the 2 liters or 2.5 liters of fluid has gone in when you need to think about balanced crystalloids, right? What is the detrimental effect of saline after you cross the 2 liters? Where is the main problem? What are the main problems with saline? Where is it causing harm?
Mostly in renal efferent arteriole, sir. The hyperchloremia leads to efferent arteriole constriction, lead to pre-renal AKS.
Do you have any evidence for that?
Evidence like smart.
Have you heard about split? Have you heard?
Yes, sir.
Split, SMART ER, and SMART ICU,
Smart
three
ICU.
trials. So, what is the conclusion of these three major landmark trials in resuscitation?
In SMART study, there is a improvement. Mortality benefit might be there, sir, and decrease in renal events and decrease in vasopressor support. In SMART, in SMART ICU there is no mortality benefit, sir, but decrease in renal events and a decrease in.
There are two SMART trials: SMART ED and
Yes,
SMART ICU.
Yes.
Okay. What is the difference between the findings of the SMART ED and the SMART ICU trial? The SMART ED trial shows that there is no difference in the incidence of acute kidney injury. There is no increase in the incidence of RRT requirement whether patients receive saline or balanced crystalloid in the emergency room. Whereas the SMART ICU trial, which has recruited patients who have received fluids before, has shown that those patients who have ongoing fluid requirement despite the initial resuscitation, if they are continue to receive saline, the incidence of acute kidney injury is higher, the need for RRT is higher compared to balanced crystalloid. So there's a difference in the cohort of patients who are enrolled in the SMART ED trial versus those who are enrolled in the SMART ICU trial. And that's where the difference is straight off the streets patients. You don't need to think about whether to give saline or balanced crystalloids. After the 2 liters benchmark is crossed, that's when you put your mind and say, maybe this patient does not benefit from saline, and you go with crystalloids. Okay. All right. How did you decide on your antibiotics? Piperacillin, tazobactam versus linezolid. Why did we go with linezolid for this patient? What is the recommended CDC, IDSA recommendation for skin and soft tissue infections with sepsis and septic shock and necrotizing fasciitis? What is the IDSA recommendation? How did we decide on going with linezolid? And what are the adverse effects of linezolid on this patient?
IDSA recommendation for cellulitis or mild skin and soft tissue infection, they preferred for initial clindamycin, sir. Mostly gram anaerobic, anaerobic cover might be more with clindamycin. For this patient, the deep fascia is already involved, pain is out of proportion, the rapidly progressive skin infection was there. So empirically, we started on linezolid for a better toxin effect compared to clindamycin in necrotizing soft tissue infections, and better toxin effect and better penetration into the tissues, and might be a chance of MRSA cover compared to clindamycin, sir. And
are we suspecting MRSA in this patient?
Less likely, sir. But rapidly progressive infection, we thought of my problem. There is a little chance.
Okay. What is the adverse effect of linezolid on this patient?
Might be one fluid overload might be chance, and another one thrombocytopenia,
Yes, sir.
but initial
No.
stages it is very unlikely, sir. That's it.
The most important adverse effect in shock is lactic acidosis. Linezolid produces lactic acidosis.
Lactic acidosis.
Yeah. So in a patient who opened his lactate at 5.8 with a skin and soft tissue infection where the lactate can be generated both from the hypoperfused tissue as well as the necrotic muscle, addition of another agent like linezolid, which can worsen the lactic acidosis, can confound your interpretation of the lactate. And sometimes you make decisions on initiating RRT or putting them on extracorporeal supports based on lactate values. And that is the confounding factor. So linezolid, you have to weigh your options when you're treating a patient with hyperlactatemia, lactic acidosis, and septic shock. Unless there is an overwhelming evidence that this patient has had an exposure to gram-positive antibiotics, this patient has an endocarditis, or this patient has a gram-positive pneumonia, where the penetration of other antibiotics is not as good as with linezolid, we should keep it as your second or third option. There are other options like, as you said, clindamycin, there is teicoplanin, there are other gram-positive. Piperacillin itself is a gram-positive antibiotic.
Gram-positive cause.
So, yeah, so we should look at it. We should consider that as well. Right? Why was his GCS low? Not normal. His GCS was 13/15, if I understand, if I remember from your presentation. Why do you think his GCS was poor?
One is he was dehydrated, sir. Another cause might be any septic encephalopathy, sepsis induced drop in GCS.
So before the culture, what are the potential possibilities or organisms causing necrotizing fasciitis?
Organism
Streptococcus.
Streptococcus, staphylococcus, and group A streptococcus most commonly in
He had
Clostridium perfringens, one possibility, sir.
How do you
So suppose
classify
it was-
based on organisms necrotizing fasciitis?
Sir,
How do you classify necrotizing fasciitis based on organisms? There are 4 types, no?
4 types, sir. Type 1 is polymicrobial, sir, and type 2 was group A streptococcus and staphylococcus, and type 3 was with Vibrio and aerogenous with Clostridium perfringens, sir. Type 4 was fungal, sir.
Gas gangrene is common in which types?
Type 3, sir. Three gaseous is type 3, sir. But type 1 also, some gases might be because of anaerobic involvement is there.
Yeah.
So when perfringens, Clostridium perfringens is one of your differentials, how do you diagnose it and what is your treatment strategy for gas gangrene?
Gas gangrene, immediate debridement was the primary option, sir, followed by metronidazole might be one option, sir. Better option, sir, compared to penicillin with metronidazole.
So you need to first consider whether it is active gas gangrene or not. If it is active gas gangrene, you need to give an antidote for the gas gangrene because no amount of antibiotic will reach the necrotic tissue. Previously, anti-gas gangrene serum used to be given, but now they are saying even if you give immunoglobulins, it is quite good. That's the first point. Second, in cities and centers where there is availability of hyperbaric oxygen therapy, HBOT should be part of your treatment plans for patients with clostridial necrotizing fasciitis, which is a limb-saving intervention to use hyperbaric oxygen therapy, right? Okay. If you put sepsis and septic shock aside, was it not simple infection-related diabetic ketoacidosis?
Yes, sir. Sepsis-induced, stress-induced hyperglycemia might be possible.
It's not hyperglycemia. Patient
no.
has 300 plus
300
sugars,
plus
cyanogenic metabolic acidosis, right?
Yes.
So it could be DKA. There could be an associated DKA also in this patient, right? We should keep it in your, because your therapy, the fluids you give is the key in treating DKA, and overzealous fluid is the killer in sepsis and septic shock. So you need to hit that balance between resuscitating a diabetic ketoacidosis versus resuscitating a septic shock alone. And especially when you had a hypofunctioning myocardium because of metabolic acidosis, right?
Yes.
Yes.
Is there
Any
any
other
evidence for
causes? Sorry. Yeah.
Go on, Sunil. Sorry.
Any other causes of AKI here? What are the likely causes of AKI in this patient?
Dehydration might be one cause there, and
Okay.
decrease in oral intake was there since last
Okay.
1 to
And
2 days.
volume? Anything else?
And one cause is septic.
Sepsis. Okay. Is that what you said just now?
Yes,
Yes,
sir.
yes,
Sepsis.
sepsis.
Okay.
Sepsis
Sepsis.
and dehydration.
Pre-renal sepsis. Anything else? Particularly in the context of soft tissue infection, something that you would want to look for?
Yes, sir. Like my rhabdomyolysis might be one possible.
Yeah, rhabdomyolysis is also something you would be, if you're telling necrotizing fasciitis and there's in myositis or involvement of muscles, that is something you would always want to check, isn't it? Yeah.
Yes, sir.
Right.
What is the one aspect in your entire presentation which makes rhabdo still possible in this patient? Can you show me his creatinine? So what does that tell you? When you look at the blood urea by serum creatinine correlation, what does it tell you? When the creatinine rises disproportionate to the urea, right? Disproportionate to the urea in a patient who has a skin and soft tissue infection, especially if he's been non-oliguric like your patient was. He had AKI, but he was non-oliguric. So if the creatinine is disproportionately high when compared to urea, hypovolemia is not the cause of the AKI. You need to consider muscle injury as one of the contributors for the creatinine rise disproportionate to the urea. And in current weather conditions, heat stroke is one such condition where you get a disproportionate rise in creatinine compared to urea. Polytrauma, for example, statin-induced rhabdo, for example, right? So all these conditions we need to keep when there is a disproportionate rise in the creatinine compared to the urea and blood urea nitrogen. Okay, that is one hint why Sunil is asking, did you consider rhabdo in your patient? Okay, all right. What is the role of extracorporeal blood purification therapies in this way? What are all the extracorporeal blood purification techniques which have been used in patients with severe skin and soft tissue infections with multi-organ failure?
Like recent one polymyxin trial, Tigris, sir. Tigris. It shows mostly in endotoxic shock syndromes, like with absolute endotoxic values of more than 6.6 to 0.89 with multiple organ dysfunctions. There had some subgroup with possibility of decrease. There is no mortality benefit as of now, but a decrease in some
Right. So when this question is asked, what are the extracorporeal blood purification techniques? You first start with RRT.
RRT, sir.
RRT is a blood purification technique. You need to talk about high volume hemofiltration and combined plasma filtration adsorption. You need to talk about HVHF. You need to talk about CPFA. And then you speak about SLED versus CRRT in patients with sepsis-induced AKI. Sepsis-induced AKI. Then you talk about the role of plasma exchange in patients with Stevens-Johnson syndrome and toxic epidermal necrolysis. Compare plasma exchange with immunoglobulins and steroids. Then you speak about endotoxin removal. So endotoxin removal, because the evidence is very flimsy and very early and very small body of evidence. You need to start with the established techniques like SLED, CRRT, CPFA, HVHF, and then you progress to extracorporeal blood purification techniques. Okay.
Okay,
Would
sir.
you have given steroid to this patient? What is the current status of steroids in the management of sepsis and septic shock?
If worsening vasopressor support, rapid worsening of rapid increasing dose of noradrenaline, in that kind of patients, we can use steroids, sir, because it will decrease the the research suggested it might decrease the vasopressor support, but there is no improvement in mortality benefits, sir.
What was his HB? HB is okay. When would you consider albumin in the septic shock? This patient 3.2, I guess, not a bad albumin, but when would you consider albumin in patients with sepsis and septic shock?
Large volume crystalloid resuscitation. If a patient needs suggest of any further volume requirement, in that cases we can use albumin, sir, according to recent guidelines, 2026 sepsis guidelines.
How do you keep assessing your patient on, I mean, you said large volume resuscitation and all that stuff, no? So what is your resuscitation protocol? When the patient you're first seen in the ER, how do you approach the resuscitation part? Because I know you have given some 1.5 liter and all that. So what is going to be your resuscitation protocol? And assessment as well, both.
Yes, sir. For peripheral perfusion, we can check for the like capillary refill time.
How do you check?
Yes, sir.
Yes,
Initially
4
we check
seconds, sir.
4 seconds, sir.
Huh?
4 seconds, sir. CRT.
No, how do you check? How do you check?
How do you check? At distal ventral part of the distal phalanx, we can apply the pressure with a glass microscopic slide for about up to we apply the pressure up till the skin was blanched completely, and we have to wait for around 10 seconds. Then we remove, and with the chronometer we can check for the normal skin color at what time it achieved. If less than 3 seconds means normal, sir. More than 3 seconds.
CRT is one. Anything else?
Lactate.
Lactate,
Sir,
sir.
based on lactate, we
Lactate.
resuscitate, sir.
Resuscitation.
And
So what is the lactate drop that you would want over what period of time?
More than 20% in 2 hours, sir.
Anything else?
So, based on IVC collapsibility and even based on VTI, sir.
Collapsibility, I think Dr. Srinivas already spoke to you,
Yes.
no? In a spontaneously breathing patient, collapsibility is like putting tossing a coin. The sensitivity is hardly around 55%. So AUC is 0.58 or something like that. So which is not a very good indicator. If it is very low, yes, it does indicate. But 1 centimeter is here and there. Anything else?
And the dynamic parameters for fluid resuscitation.
Okay. What are the dynamic parameters you can do on this patient?
PLR, vasoagress test. With
how do you do that?
So we make the patient sit in 45-degree position, sir. And then after patient is in 45-degree position, we instead of
we have to be specific bed will be there, sir. We can't do every bed.
No.
There have to be specified beds for vasoagress test.
So, sir, because of the once we'll put the leg up, sir, around 250 to 500 blood volume.
No. Tell me the method. So
Sir,
yeah, when you get sit the patient up for 45 degrees, then
after that,
so let us say you have the bed,
Bed down.
the appropriate bed. Then
Yes, sir.
what next?
With,
So we'll keep the patient in 45 degrees. After that, we'll make the patient head down and leg up, sir, in 45 degrees, sir. And in that position, if the cardiac output increases more than 15.
How long do you keep that position?
30 seconds. 30 seconds.
Is it you just raise the leg up and then look at the cardiac output, or?
No, sir.
So that bed is there, sir.
No, bed I know. Yeah, bed you
with
the
after
bed, leg end of the bed, agreed. Then
on continuous monitoring only we have to do, sir.
how much time do you to wait to check?
60 seconds. 60 seconds.
Yeah, 60 to 90 seconds only. Then you take the value. Not the act of getting
Not
up can only itself cause the cardiac output to go up. So increase in cardiac output by how much?
15%, sir.
15.
Yeah, if cardiac output is not available, which is the next best reading will you use?
BTI.
VTI, you have to keep checking, no? Anything else?
Pulse pressure.
Pulse pressure.
Pulse pressure is the second best. Yeah. Okay.
So let me ask you one question. You gave this patient 30 ml per kilogram of body fluid, and then you kept him on 80 ml per hour of fluid on a regular basis. What is the rationale?
Like
Is it part of resuscitation, or are you catching up with fluid losses from the exposed skin? What is it that we are trying to achieve by giving that 80 ml per hour of fluid on a regular basis for such patients?
like initial like after resuscitation optimization, sir, insensible losses, debridement, extensive debridement was done, and still requiring vasopressor support. Still lactates are very high. Urine output is more than 0.5 ml per hour per 0.5 ml per hour per kg is there, sir. That's why we calculated with keep on regular assessment, fluid assessment. We continued on 80 ml fluid.
So it is not part of resuscitation. That 80 ml per hour cannot be a resuscitation.
Optimization.
If a patient requires fluids, you assess for fluid responsiveness and then you give boluses of fluid. This maintenance fluid is the one that causes the fluid creep. This maintenance fluid is the one that causes the cumulative fluid balance in these patients. That is the most important thing to remember. There's no effect of this continuous running of 80 mLs per hour of fluid in septic patients to maintain the balance. Yes, you lose fluid through burns, you open wounds. That's a different ball game. It's just maintaining the even balance. So, but that should not be considered as part of your fluid resuscitation strategy, or it should not be considered as the policy. I have two observations. Your patient was started on pantoprazole, right? And I did not see any DVT prophylaxis being spoken about on this patient. So now let us talk about the current status of stress ulcer prophylaxis in critically ill patients. What is the current status of, what is the current evidence and the strategies to follow? And I'll complete. I didn't find a nutrition plan for this patient. So how are you going to feed this patient in sepsis and septic shock on vasopressor support? So three questions. What is your strategy? What is the current status of stress ulcer prophylaxis in sepsis and septic shock? What is your DVT prophylaxis recommendation for this patient? And what is your nutrition strategy for this particular patient?
For DVT prophylaxis, there is a strong recommendations, like the grade 1 recommendations, a strong recommendation in recent guidelines with low molecular weight heparin, and with compared to pharmacological compared to compared with the IPC pumps, mechanical pumps instead of mechanical pumps, and for in view of debridement, multiple debridements plan is there, sir. That's why we didn't start any pharmacological prophylaxis.
What is the contraindication for giving unfractionated heparin in this patient? If a patient is scheduled to go for debridement, you stop it 6 hours prior and he goes. And this patient most probably will get debridement done under a block, right? Not even a neuraxial anesthesia. So what is the contraindication for unfractionated heparin in this patient?
Till coagulopathy was there, sir. INR 1 point, but IPTT values
20.
IPTT was normal. Platelets were normal. He is a hypercoagulable patient. He is a hyperosmolar patient as far as the blood sugars are concerned. And his initial problem was pain. We don't know what is the status of the deep veins in the leg, because you can't do a Doppler on, and when there is like active inflammation. So he is a candidate for dual prophylaxis, compression device on the other leg and pharmacoprophylaxis for systemic. Yeah. Second point, what is the current status of DVT prophylaxis? When prophylaxis among patients with sepsis and septic shock.
Sorry,
Sir,
sir.
So your voice was
Voice
breaking,
was-
sir. We were not able to.
What is the current status of stress ulcer prophylaxis among patients with sepsis and septic shock?
DVT prophylaxis, sir.
No, stress ulcer
Stress
prophylaxis.
ulcer prophylaxis, sir.
In GI bleeding, sir, they have told that we should use, sir, patients with the higher chances of GI bleeding, sir. We should use, they have told better to use proton pump inhibitors and H2 and blockers, sir.
No.
But
The current recommendation is for those patients who are hemodynamically stable, are not coagulopathic, and are not hypoxic. The benefit of adding stress ulcer prophylaxis with proton pump inhibitors is not there. In fact, you are increasing the chances of sudden cardiac death in these patients because of QT prolongation caused by pantoprazole. But if the patient is on vasopressor support, if the patient is coagulopathic or hypoxic requiring FiO2 of more than 60%, then there is a definite benefit with the use of stress ulcer prophylaxis. Okay.
Okay.
This is a SUP-ICU study recently published about 3 years ago. Right? What is your I didn't see a nutrition plan for this patient. That should always be part of any critical care presentation, whether it is traumatic brain injury, whether it is septic shock, whether it is cardiogenic shock. You're talking about burns. Nutrition plan is a therapy. Just as you said, I gave optinuron to this patient, I gave thiamine to this patient. We should also prescribe nutrition for patients in sepsis and septic shock. What was your nutrition plan for this patient, and what is the current status of feeding patients with sepsis or with shock requiring vasopressor support?
Patient, we have to, sepsis with septic shock, we have to start as early as within 72 hours. We have to start the oral feeding, sir, oral or enteral feeding.
So patients with the high requirement of vasopressor support, sir. So immediately we can't give the total protein requirement for the patient, sir. So we'll start with very minimal dose of 20 to 25 ml
How much?
per hour, sir.
It's not ml. How many calories is considered good enough? Good enough. How many calories per day is good enough for patients on dual vasopressors?
20 to 25 kilocalorie per kg per day. We calculate.
No, that is normal requirement for a critically ill patient, right? But in a patient in shock on vasopressor support, what is the acceptable calories which you can give without compromising his gut integrity or promoting translocation of bacteria?
50% of daily requirement I have to start, sir, initially.
No, the Nutriria 3 trial has clearly shown that up to 600 calories per day is safe and is essential to maintain the mucosal integrity of the gut in patients receiving vasopressor support. Beyond that, it becomes overfeeding of these patients and you cause more harm to these patients. If you try to achieve 1200, 1800 calories when patients are on dual vasopressors, you cause more harm. Up to 600 is safe and you should try to achieve it, because feeding the gut is the best stress ulcer prophylaxis. It's not pantoprazole, it's not sucralfate, it's not anything else. It's feeding the gut. Okay.
Yes.
What is the current thinking about thiamine in patients in shock? What is the current status of thiamine in patients in shock?
No, not routinely recommended, sir. But it's in several trials, it also suggests of if any patient is thiamine deficient, in that patient only it helps, sir. In normal routine, thiamine requirement is not required in every patient, sir. In septic shock, mostly we have to give for if thiamine has act as a cofactor in like a Krebs cycle, it might help in to the clearance of pyruvate to acetyl CoA, sir.
Right, Venkat, what do you want to do now? We have 1 hour. Venkat, are you there?
Yes, we can continue, sir. We can continue. There is no limit for that. I think there is a good discussion happening. We had 200 plus students eagerly watching for you.
Okay, so there was a question by Dr. Ghazia who asks us, how do we start DVT prophylaxis in a patient with long stay in the ICU, recovering from thrombocytopenia and underlying coagulopathy? Would one of you answer that? Vinay, Ankita, your answer. You answer that question. One of your colleagues is asking that question.
We can start with the low molecular weight heparin, sir.
Underlying coagulopathy is her question. So we need to define what that underlying coagulopathy is.
That's fine.
Yeah.
Recovering
Underlying recovering coagulopathy.
Yeah.
So we should always try to establish pharmacoprophylaxis. If the hospital has an access to a point of care viscoelastic testing of coagulopathy, we can use that like a ROTEM or a TEG. If you don't have that, it's a trial. You give low molecular weight heparin and see what's happening to the platelet count, and you see what's happening to generalized bleeding tendencies, because there is no definitive test at this point which says this bleeding is due to low molecular weight heparin. Fondaparinux is one thing which can use even in thrombocytopenic patients. We can use that. But what is the coagulopathy due to? Is the coagulopathy due to hepatic dysfunction, or it is a part of the DIC? Now, in patients with DIC, it is a treatment of the cause. In hepatic dysfunction, there may be a role for vitamin K. There may be a role for prothrombin X complex concentrate. But we don't know how effective they are in septic. So you should start either with unfractionated heparin or with low molecular weight heparin. Anupama's question was de-escalation of vasopressors in sepsis. Now, that's a difficult question. Before we go that, I want to ask both of you. This patient was on telmisartan. Okay.
Yes.
What is the relevance of ARBs and ACE inhibitors in the etiopathogenesis of shock in patients with sepsis? Yeah, so these drugs are known to be acting on the renin-angiotensin-aldosterone axis. Now, septic shock is being categorized into low renin septic shock and high renin septic shock. In those patients who are on low renin type of septic shock and have been on telmisartan, the refractoriness of shock is more. These are the patients who are more likely to benefit with angiotensin 2. Unfortunately, we don't have it yet in this country, but that's the third vasopressor. Like you have norepinephrine, which is acting on the sympathomimetic receptors. You have vasopressin, which is acting on the aquaporin receptors, and you'll have angiotensin, which is acting at the angiotensin receptor. So that's the third vasopressor. So it may be those of you who will appear for theory exams, the renin-angiotensin-aldosterone axis in sepsis, or renin the new lactate. It will be the question which you have to give evidence and pathophysiology.
Yes.
Right? You have to remember that. Anupama's question was de-escalation of vasopressors in sepsis. Now, that's a very tricky question. There are some patients who are non-oliguric and will require dual vasopressors. In such patients, the vasopressin should continue at least 0.01 units per hour till the norepinephrine comes down to about 0.05 mics per minute. Then the vasopressin comes off. In oliguric patients or in those patients who are rising lactate, dysfunctional gut, or at high risk of acute coronary syndrome, the vasopressin should be the one that comes off first. So that's the short answer to that question. Uh, what about sepsis cholestasis? Dr. Shivprakash wants to know, how do you manage the cholestasis of sepsis? What is your view on that?
Mm. Early initiation of feeds.
No, so the sepsis related cholestasis is just a manifestation of the dysfunctional gastrointestinal tract. So you treat the sepsis, you will get it. But there are some patients who become encephalopathic because of hyperbilirubinemia. You may use binding agents like ursodeoxycholic acid in these patients, but if the gut is not functioning, it won't work. There may be a role for hemabsorption with bilirubin adsorbent cartridges. That brings us to the last question. The other question we have from Dr. Achyut, who's asking you guys the role of adjunctive therapies for sepsis in this kind of patients. What is your take on adjunctive therapies?
In this,
I think we discussed
yes,
about filters. I think we discussed about different filters. We discussed about steroids. We discussed about thiamine. These are all adjunctive therapies. But let me ask you one adjunctive therapy. What is your take on the use of methylene blue in these patients?
In this patient, there is no worsening of shock, sir. If a worsening of shock, patient is on high vasopressor support requiring adrenaline. In that last resort, we can use, but evidence-wise, there is no conclusive evidence. It will help in.
A trial is coming, sir, Empress trial, sir, which is right now, like they're trying to see whether within first hour of using of methylene blue, sir, whether it is helping or not, sir, because during the first 8 hours, sir, there is higher amount of nitric oxide release and inducible nitric oxide synthesis is high, sir. So plus, so they are trying to see, sir, but that results are still awaited, sir. How?
Yeah, so adjunctive therapies at the moment, none of them seem to be working for sepsis. Okay.
For cholestasis, remember also to look at your drug card. Certain
Yeah.
drugs, especially the beta-lactam inhibitors, if you're having clavulinate, high doses of that can also keep the process going. So sepsis might cause cholestasis, but remember the drugs also, make sure your drug card is looked into, and if you can stop whatever is causing it, stop it as well.
Okay.
What about Sepsivac? Sunil, you have any clue on Sepsivac?
No, I think there's no evidence of its support. It's again one of those immune clearance kind of things. I don't think there's much role for this. I think most of the immune modulators in sepsis have not much role other than what we saw was for steroid. That also is only for reduction of the suppressor-free days.
Okay, how to deal with isolated high bilirubin levels like more than 20? So it is possibly a very dysfunctional gut which is causing. So the earlier the gut starts working, the earlier the bilirubin goes up. Otherwise, you can use extracorporeal removal with the bilirubin adsorbent cartridges. Dr. Deepak, I didn't get your question because you said kindly reply. I searched for your question. I couldn't find it. Would you mind posting it again so that we can try to answer it? Dr. Deepak Tank. Okay, while we wait for that question to come, is there any role of plasma exchange? Unfortunately, no evidence to say plasma exchange works in sepsis at this point, except isolated patients with toxic shock syndrome and toxic epidermal necrolysis.
Group A streptococcus involvement.
Yeah. Please emphasize the role of IV albumin. IV albumin replacement is never a issue or a fact to consider. You don't replace albumin first of all. Second, when do you use albumin for resuscitation? When do you use albumin in patients who are hypoalbuminic as defined by an albumin of less than 25 grams per liter with ongoing fluid resuscitation and hypoxemia, uh, then there is a role for giving albumin as a resuscitation fluid, but it is not to replace the serum albumin. You don't target it. It is just to improve the hemodynamic response. IVIG has got good evidence for the management for septic with the toxic epidermal necrolysis and Steven-Johnson syndrome. There is good evidence for both. Thyroxine supplementation in sepsis, no indication. It is sick euthyroid syndrome. You don't supplement it. Cytosorb cannot be used routinely. Cytosorb is only in the presence of a cytokine release syndrome and a macrophage activation syndrome before the steroids and other immunomodulatory therapies have started to become effective. Selective digestive decontamination, we'll ask our friends Vinay and Ankita what you are understanding about SDD. There is a recent study, last week it was published, SDD ICU trial. What is its role in current day practice?
Actually, in low resistance centers, in like low antibiotic resistance ICUs, we can try with to cover gram negative and 2 gram like oral topical agent of polymyxin, amphotericin B to cover gram positive, gram negative organisms except anaerobes, sir.
Yeah, so selective digestive decontamination has been tried for several decades, has not shown to be of benefit, except for one trial in Netherlands, which has shown some benefit. Repeated trials have not replicated the results of the Dutch trial, but again, on the one Dutch trial, on one trial basis, the Surviving Sepsis campaign has made a recommendation that it should be considered, which I don't agree to. Acinetobacter in BAL without consolidation. It does not warrant systemic antimicrobials unless there is a decrease in the compliance, increase in the FiO2 requirement, or the sputum load of the patient. You can try nebulized antibiotics for these patients. How to navigate inotropes if septic cardiomyopathy is present? It's a big question. You can use dobutamine for some of these patients. You can use levosimendan, but it has not shown to be of much benefit. Milrinone can worsen your hepatic function, so you have to balance it. There is an emerging role for IABP in these patients, and there is an emerging role for ECMO in these patients if the cardiomyopathy produces cardiogenic shock. No, I don't want to give parenteral nutrition. I would like to give nutrition through enteral route. This GI bleeding, yes, I would first try to correct the coagulopathy, do an endoscopy, identify any potential treatable cause of bleed, and then feed the patient. But I am not a great fan of parenteral nutrition. I would like Sunil also to give his views.
I would
Patient with
agree
GI
with you.
bleeding.
In fact, I
Yeah.
think the priority will be to establish what is the cause, and if it is just some erosions and things like that, definitely no stoppage of feed. Unless you have a point bleeder, which can be tackled with endoscopy. But I think stopping, I mean, it's a very knee-jerk reaction. Little trickle of blood, stop feeding. Very commonly done by all of our trainees as well. I think that is first thing is that's not the answer at all. In fact, as Dr. Srinivas already mentioned, that is the protection that you are giving. So keep the feeding going. And there's no reason to stop feeding unless it's a torrential bleed and you have some procedure which is being planned and that is interfering. But once you are confirmed what is the bleeding, you start feeding them. There's some how much max dose of vasopressor for refractory shock? There is no max dose per se. I think it is
as
subject. Yeah. As long as it is not causing negative impact of causing other secondary effects like end artery thrombosis or end digital ischemia, and if you are desperate to actually protect the defend the hemodynamics, then you have probably not much choice. There's a question below that. 34-year male, pneumonia, ARDS.
Asking about ECMO.
ECMO.
Cytosorb and ECMO.
Cytosorb, well, it's not of much help. I'm not a big fan of it. I mean, the only thing it might help is probably decreasing the vasopressor requirement, but that also, as you know, there's not very strong data. The role of ECMO in vasodilatory shock is a bit controversial. There are some case studies which have shown that vasodilatory shock, it helps. You have to understand that the mechanism of VA ECMO in the context of vasodilatory shock use and pump failure are two different ways. In a situation of vasodilatory shock, you really have to give very high flows because you're using it more as a series rather than as a primary source of defense. But in the context of sepsis, I think still we don't have enough data. But in the context of certain other situations like say vasodilatory toxins and things like that, there is some role. And remember that if you are using in vasodilatory shock, you really have to use extremely high flows to use it as a series thing. But these are still in the context of case-based experience. I don't think there is data to say that it's a recommendation per se. Srinivas, you want to add anything to that? You can add.
Yeah. So the other thing is when you transition somebody onto V0 ECMO, you need to remember that you're actually increasing the afterload on the left part with the V0 ECMO. So you may be actually triggering a LV dysfunction in these patients. So we need to balance that as well. How many days of antibiotics in shock? 7 is as good as 10. No advantage unless you are dealing with endocarditis, osteomyelitis, or
deep infections,
deep infections, abscesses. Otherwise, 7 is as good as 10. That's the evidence. How can we salvage a patient from sepsis-induced cytokine storm? You have to see the cytokine storm. Is it macrophage activation syndrome, HLH? Then the protocol for HLH has to be followed.
I think that's the only thing you have to see, HLH versus non-HLH. Otherwise, it's all supportive therapy.
Yeah, there is evidence. There are a lot of guidelines which are mentioned aptomycin in sepsis for high-grade necrotizing fasciitis. There are most guidelines recommend. Polymyxin heme absorption in sepsis, Tigris trial has come in, but again, it is not a magic bullet. It is one of the therapies which you can offer to your patient, especially with those with endotoxemia, preferably of abdominal origin, where it works. But again, large volume studies are not feasible with this kind of therapy, so it is individual decisions.
In fact, I think the company itself has withdrawn that polymyxin. I'm subject to correction.
There is no. They have brought in hemophil. They have brought in hemophil with both polymyxin and cytokine adsorbent cartridge. It is available, but again, evidence is not very good.
Yeah.
So I think we have answered most questions. An excellent presentation, both of you. I think you did a very good job, Vinay and Ankita. All the best for your future. You've done a fantastic job, and your teachers have actually done a fantastic job in guiding you. Venkat, over to you.
Thank you, sir. It has been almost hour and 15 minutes, and more than 250 students logged in and out, and they're still waiting for more questions. I think it will be a never-ending story, and that brings to the bottom that how teachers both of you have been. It's almost 75 minutes. How it passed, even I could not realize. Thank you very much for your presence. And
asking questions is the easiest thing in life. Finding answers is a challenge.
It would have been realized that the starting can be from somewhere. When the teacher can understand you are ready with the basis, then they can start somewhere from that to up, so that they can come down. And that's the spectrum how the exams happens in a DM and DRNB level, from upside down. It can be from a hyperchloremia, from a MAC to phenotyping.
So, just for the trainees, remember that even if you're given a case of sepsis, the opening
Yes,
STEM
exactly.
question may be, as Dr. Venkat said, we may give it as sepsis, but we may migrate to something else, because we generally know that, getting to the diagnosis is not a big deal.
Exactly.
But I think how you handle the situation after that. So it might find that, you start somewhere, but you end up somewhere else. So just a brief thing, as Dr. Srinivas also mentioned to you, when we know that you know the diagnosis, but how do you come to that diagnosis is going to be those 1 or 1.5 sentences which Srinivas told you should be the punch to bring to the diagnosis. So you said definite sepsis, soft tissue infection with multi-organ failure or with organ failure, whatever, septic shock, etc. So you have to lead on to that diabetic with soft tissue skin infection, progressed, then, and also when you're summarizing, don't go through a detailed, even when presenting, we are not expecting you to have 4-day fever, 6-day. Please don't get into that, because you remember we have about 30 minutes or so for assessment, maybe 20 minutes for assessment, actually only 20 minutes. So finish your presentation in 3 to 5 minutes, crisp, crunchy, and to the point. And anything else we want to ask, we will ask you. So, and if possible, divide it into pre-hospital, ER, ICU, because we want you to make an impression out of each of that thing and present. And you said S1, S2 and all, it's okay here, but in the exam, what we would expect you to say is presented with shock, first sound, second sound not needed, presented with shock, and we did this and this. On my assessment today, shock is better, or he's on a single vasopressor, acidosis present, not present. So that way, so just divide it into this, and each should not be more than 2-3 sentences, so that, then you lead the examiner to the diagnosis. That's what, yes, yeah, you have to remember that we are training you to be consultants, not to be a junior doctor. So think at that level, and how you would present. If I hand over to Srinivas, how would have done it? That is how you will have to discuss with between yourself, or that's how the presentation has to be. Okay.
Yes.
Yeah.
Thank you, sir.
Thank
You
you.
want to ask us any questions? Both of you?
Yes, Vinay and I.
We are ready.
That's the reward for the day.
So that's the opportunity that most of the students are able to answer. This particular platform has been useful, as Dr. Srinivas and you has Sunil has answered many questions. This is one of the opportunity where students has an opportunity to ask, if such question comes, how do we answer? What should be our stand on, kind of thing. And I think this platform, and this will be available on recorded session both on YouTube and Facebook. So those students or colleagues of you who wanted to attend it can attend. And I think many more such sessions to come with this kind of teachers around and faculty around, many more students to get benefit. Thank you all for your kind presence, and thank you, Srinivas.
Thank you.
Sir,
Thank you, Venkat. Thank you, Srinivas.
Thank you,
Thank
sir.
you. Thank you very much. We'll enjoy the SRH match now. Thank you.
Yes, thank you.
Awesome.